Hello and welcome to my channel. In this lecture we're going to discuss the spleen and pancreas. So let's start. The spleen is the biggest lymph node in the body, and its function is not just as a lymph node. It's has things to do with blood. It's a blood reservoir in lower animals that uses it in flight or fight, and it's a blood filter in the human beings. So it's not only a lymph node. It lies in the left hypochondrium, opposite ribs 9, 10, 11 ribs, and longitudinal axis is parallel to rib 10, so it's slightly oblique anterior-inferior. It's between the gastric fundus and the diaphragm. So it's right next to the stomach on the left side. It's not palpable, by the way. It's never palpable normally. If it's palpable, so there is something wrong with the spleen. It has a diaphragmatic surface, as you can see here. It's convex surface, and a concave surface, medial surface or visceral surface that's related to viscera. In anatomical position, it will be related to the stomach anteriorly, which makes an impression called the gastric impression, the kidney posteriorly, which makes an impression called the renal impression, the left colic flexure near the tip, and a point just anterior to the hilum of the spleen is related to the apex of the pancreas. So in practical exams, if you get an identification on this point, which you doesn't know, it doesn't either belong to the renal side or the gastric side, so it's the pancreas. So it has a gastric impression, renal impression, left colic impression, and pancreatic impression, and this means that it's related to these organs medially. Has an anterior, sometimes called superior border. It's not the border with notches. I've seen spleens, notches all around the spleen, but it's the border with more notches on it. So it's the border that carries more notches. The notches is as a result, during development, the spleen wasn't one piece, was about 8 to 10 pieces of spleniules that gather together to form the spleen. And the evidence remaining about this, the development history, is the branches of the splenic artery, which divides into segmental branches before it enters the spleen. This means that each segmental branch supplied each of the spleniules during development. Okay, this plate is to show you the spleen in situ. This is the visceral surface. This is the gastric impression, as you can see here. This is the left colic impression, and here, this point is the pancreatic impression, the tail of the pancreas. See, it goes to the tail of pancreas. The region posteriorly is related to the left kidney, as you can see here. Of course, the spleen here is mobilized, but it's still fairly enough in its place. See, this is the left kidney impressing the posterior aspect of the spleen. And as you can see here, the splenic artery with its segmental branches and the segmental veins coming out of the spleen to form the splenic vein. Histology of the spleen. Of course, we're not studying histology, but just to show you the various functions of the spleen. There are regions called white pulps, which are collections you see here stained blue. These are the lymphoid follicles in the spleen. This is the immune function of the spleen. Actually, part of the humoral immunity, acts as a lymph node. And the rest is, as you see here, is called the red pulp. And if you magnify, you will find sinusoids between the the capillaries in the spleen, and these sinusoids of specific size, by which it uses to filter the blood. Any red blood corpuscle that is out of shape, like the old ones, old red blood, it's not squeezable, bigger than average, its shape is different than the biconcave disc of a red blood corpuscle, cannot pass in the sinusoid and picked up by the spleen. So this is the filter side of the spleen. The one that passes in the sinusoids, the squeezable, healthy, young RBC that can go through the sinusoids of the spleen and back into the general circulation. And the abnormal shapes, like in case of spherocytosis, like sickle cell anemia, and end result is hemolytic anemias. The spleen plays a good role in hemolytic anemia rather than diseases in blood itself. So this is just to show you the function of the different functions of the spleen. The peritoneal folds related to the spleen. See the spleen, well, there's an argument, either it's intraperitoneal or extraperitoneal. It doesn't make a difference actually. In some books you'll find it extraperitoneal, some books intraperitoneal. But anyway, it's surrounded by peritoneum and related to two double-layered ligaments, one connecting it to the stomach called the gastrosplenic ligament, this one with the two components, the red and blue component. And the same thing here is the splenorenal ligament or lienorenal ligament that connects it to the kidney. Now the question they ask you about is the contents of these ligaments. I told you this is a double-layered ligament. The gastrosplenic ligament contains the short gastric vessels coming from the splenic artery. Short gastric branches supplying the fundus of the stomach run through this ligament. The content of the splenorenal ligament or lienorenal ligament, which is the old name, is the tail of the pancreas together with the pancreaticosplenic lymph nodes. So tail of pancreas and pancreaticosplenic lymph nodes are the content of the lienorenal ligament. The arterial supply of the spleen comes through the splenic artery. I think we discussed this before. The splenic artery has a tortuous course, runs above the pancreas, partly behind the pancreas. The troughs of the zigzag course are behind the pancreas and splits into segmental branches before it enters the spleen because of the development of the spleen from splenules. The venous drainage by the splenic vein, of course. Segmental veins gather at the hilum to form the splenic vein, which is not of a tortuous course. It's not zigzag-like, and it's straight, and it's beneath the artery, inferior to the artery, right behind the pancreas. Actually, it sticks at the back of the pancreas. So one thing to mention here about the blood supply in surgery in cases of splenectomies. First of all, you should retract the spleen medially. Retract it medially, not laterally, so as not to cut the structures entering it, and especially the tail of the pancreas, which hits the spleen in front of the hilum. So you retract it medially, and when you excise and devascularize the spleen before excision, take care not to injure the tail of the pancreas that has an intimate relation with the spleen. This is to keep in mind using your anatomy knowledge about the blood supply of the spleen. This is to show you the zigzag course of the splenic artery. See, and how the troughs are behind the pancreas, while the artery itself, rest of the arteries, the peaks, are above the pancreas. The splenic vein is beneath the artery and it's behind the pancreas. This is the splenic vein, formed of the segmental tributaries that gather to form the splenic vein, that eventually will join the superior mesenteric vein to form the portal vein to the liver. You may encounter cases of rupture spleen in which it's responsible for a serious internal hemorrhage, especially if there is a fractured rib, especially ribs, of course, 11, 10, or 9, which are directly related to the spleen. Splenomegaly has many causes in which the spleen gets enlarged, and it's not surprising that in clinical exams, if you're asked to palpate for the spleen, the doctor watches you. Where are you going to start? You should start from the right iliac fossa. Right iliac fossa. Because the spleen is resting actually on the phrenicocholic ligament, and it directs the growth of the spleen downward and to the right, and it may reach, and I did palpate spleens in the right iliac fossa. Imagine, so the size is occupying the whole abdominal wall. Actually, it was a huge spleen. And how can you identify the mass palpated as spleen? Because you can feel the notches on the border during palpation. This is the way to identify the mass as being a spleen. And also, since it's related to ribs 9, 10, 11, so you expect lateral to the spleen, the costal surface, the convex surface of the spleen, to be related to the diaphragm, then to the costodiaphragmatic surface, costodiaphragmatic recess. And above it is the lung. So in case of needle biopsies, especially of course in the 9th space, 10th space, 11th space, be careful not to avoid these spaces so as not to cause pneumothorax. You should have a different approach, not a direct approach, to obtain a needle biopsy from the spleen. Okay. For the pancreas, it's a soft lobulated organ, very soft, very, very soft, and you observe that in dissection, and it's lobulated as you can see here. It runs across the posterior abdominal wall, occupies first the C concavity of the duodenum, and then goes up to the left on its way to the spleen. It has a head that occupies the C concavity of the duodenum. An uncinate process, uncinate means unseen because it's hidden by the superior mesenteric vessels. After the head, we have a neck and body and tail of pancreas that runs in the splenorenal ligament. The head is posteriorly related to the common bile duct and superior mesenteric artery and vein. The vein joining the superior mesenteric vein to form the portal vein. To be precise, it's behind the neck, somewhat behind the neck, the joining of the splenic and the superior mesenteric. The superior mesenteric vein and artery, the vein on its way to behind the pancreas and the artery on its way out of the pancreas, originated behind the pancreas, both cover the uncinate process. The uncinate process, it's like a hook at the lower aspect of the head of the pancreas, and it has its own pancreatic duct called the accessory pancreatic duct. Transverse mesocolon attached anteriorly. The pancreas, and if you take a cut section, it has a triangular shape, The apex of the triangle is directed anteriorly, and it has a posterior superior border and a posterior inferior border and an anterior border. To this anterior border, the mesentery of the transverse colon begins. The root of the mesentery, the root of the mesocolon, is attached to the anterior border of the pancreas. Neck is related anterosuperiorly to the pyloric antrum, and if you put all the organs together in anatomical position, you will find out that the neck pushes the lesser omentum against the liver in an area on the liver called, or eminence on the liver, that fits with the lesser curvature of the stomach, called the tuber omental, and the tuber omentale will be discussed with the when we study the liver. I think next lecture. The peritoneum, it's retroperitoneal structure, not intraperitoneal, and the transverse mesocolon attaches to its anterior border, and the tail runs in the splenorenal ligament, which is derived from peritoneum. So these are the peritoneal relations of the pancreas, if we want to talk about them. Relations of the pancreas: anteriorly is the greater omentum, lesser sac, of course. Anything behind the stomach is separated from the stomach by the lesser sac, and the mesocolon attached to the anterior border. Inferiorly, there's superior mesenteric vessels, duodenojejunal flexure, and the left colic flexure. Posteriorly is the aorta, origin of superior mesenteric artery, the left suprarenal vein, the left kidney and vessels, the splenic vein. Please don't try to learn these by heart. Just when you study each individual organs and you put them together, try to figure out the relations yourself, and you will find out that you are actually reciting the whole. You are actually memorizing all of the relations you may be worried about. The tail runs in the splenorenal ligament, as I told you before, and it's liable to injury in splenectomies. Okay, the duct system of the pancreas. It has two ducts: main pancreatic duct, as is the one you see here, and the accessory pancreatic duct that drains the uncinate process of the pancreas. The pancreatic duct is described as a herring spine because it has minute, long tributaries that form the main duct. This is only the main duct present here, without the canaliculi that forming it. And this is the accessory pancreatic duct. As you can see here, it opens in the posteromedial aspect of the duodenum, in the minor papillae, which is above the major papillae, which is the site of the opening of both the common bile duct and the main pancreatic duct. And it's beautifully dissected here, the bile duct. See, as it meets the pancreatic duct to push the mucosa into what's so-called the ampulla of Vater, and it's guarded by a sphincter called the sphincter of Oddi, and this is where you go when you inject a dye with ERCP, endoscopic retrograde cholangiopancreatography. This is that was the about the duct system of the pancreas. We use the anatomy information that the head occupies the C shape of the duodenum. So if you're suspecting something wrong in the mass occupying lesion in the head of the pancreas, you just make a barium meal. So this is indirectly visualizing that there is something wrong in the pancreas, because any mass occupying lesion will distort the C shape of the duodenum. This is what you look for if you're investigating the pancreas with a barium meal. Of course, you will encounter many cases of pancreatitis because of the alcohol abuse, and jaundice in case of pancreatitis. Explain the jaundice. Yes, exactly, because it opens in common with the common bile duct, or any space-occupying lesion will affect the common bile duct, and this is reflected on the body by jaundice. For the blood supply of the pancreas, the head is supplied by superior and inferior pancreatico-duodenal arteries. See, these are the branches of the superior pancreatico-duodenal coming from the gastroduodenal artery, and this is the superior mesenteric with its inferior pancreatico-duodenal branches supplying the duodenum and the uncinate process part of the pancreas. So the pancreatico-duodenal supply the head and the uncinate processes, but the neck, body, and tail are supplied by the splenic artery, branches that form a major artery inside the substance of the pancreas called the arteria pancreatica magna, or the great artery of the pancreas. So this is the blood supply of the pancreas. The venous drainage of the pancreas is through the splenic vein, which drains into with the superior mesenteric vein into the portal vein. The lymphatics, there are various lymph nodes scattered around the pancreas. You can call some pancreatico-duodenal, pancreatico-splenic, pancreatico-splenic along the posterior aspect of the pancreas, pancreatico-pyloric, near the pyloric antrum, and retropancreatic nodes behind the head, and all of these eventually will drain into the celiac lymph nodes. The innervation is sympathetic through the celiac plexus, and of course the plexus that it sends around the arteries, and parasympathetic through vagi, because we're still in the area of the foregut. So the celiac trunk is the artery of the foregut, and it delivers the plexus around it, which is contributed to by the vagi. And the pain coming from the pancreas radiates to it's characteristic to that it radiates to the back, you can pinpoint it in the center of the back, along, of course, the sympathetic supply. The sympathetic is the autonomic nerve that always carries, together with its autonomic function, it brings the pain sensations from the viscera. So this is the basic anatomy of the spleen and the pancreas. I hope you got the maximum benefit from this lecture, and thank you very much for watching.